Can you see the slides?
No, sir. Praveen, you stop sharing.
Yes, sir. He can share now. We are
You
not
can
sharing
share
anything.
now, sir. Rajesh.
Yeah.
Rajesh, sir, you can share.
Just a minute. So now it is my slides are on. Can you see the slides?
Not yet, sir. So you need to
Not
just that share screen, sir. In the Zoom, there is called share screen, no, sir?
Just a minute.
Yeah.
We have to learn this Zoom business.
Can you now see?
Not yet, sir. Rajesh, sir, you just keep that PPT open, presentation.
Okay.
Then come back to Zoom screen.
Yes, I did that.
But when you say share,
Share content.
Yeah.
Then it is a screen.
Yeah, select that screen and below there is a one option called share. You have to click that share again. Now, yes, I can see other window. Yeah, you are now sharing a screen. I can see the window. Yes, how do I do high risk hip? Yes.
Okay.
Edward, sir, visible, right?
Yes, sir, it's visible.
Yes.
But it will be like this one.
No, he has to click on that play slideshow, sir. Rajesh, sir.
Yes.
Just click on that play slideshow.
Yeah.
Yes, sir. Now how it will look like.
Okay. Because it's in the iPad.
Yeah.
Okay. Okay, sir. We can stop sharing, sir. We can start the work.
Yes, I'll stop for him. Sir, Rajesh, sir, I'll stop for the time being. Then later we do the same procedure.
Okay, sure.
Edward, sir, I'm going live now.
I have admitted everyone. I can start live. Shall I go, sir?
Just a minute, second, sir. 1 second. I'm going live.
Shall I, Praveen?
Yes, sir, you can.
Good morning. A warm welcome to online anesthesia update, a Zoom platform, a teaching program for the consultant, sponsored by Akrula and hosted by A1 Logics and aired by Anesthesia TV. This is the second session of this year. Today we are having an interesting topic of high-risk patients coming for hip surgeries, how I do it. For that, we have two eminent scholars in our forum. That is Dr. Sekhar, the HOD of Ganga Hospital, Coimbatore, and Dr. Rajesh Shah, Medical Director of UNM Children Hospital, Surat. Today's session is coordinated by Dr. Sivaprasad sir, our colleague. Over to you, Sivaprasad sir.
Thank you, sir, and a warm welcome to all our participants. Today we have a very interesting session in our consultant session, how I do it. That is for the hip surgery. Commonly, we have many doubts because these patients are old, they are on medications, they are all coexisting diseases. So here we have two eminent speakers who are going to enlighten us with how they do their own sessions, not pro-con, but they will enlighten us on how they do it. First, I welcome Shekhar Chalaya sir and Rajesh sir. Shekhar Chalaya sir is the head of Department of Anesthesia in Ganga Hospital. He has done his medicine MBBS from Coimbatore Medical College in 1980 and his MD Anesthesia from Mahe Manipal in 1995. And from that time, he is an active anesthesia strategist practice in Ganga Hospital. And if you look at his CV, you have a long list of the lectures, the publications he has done, and has also given so many innovative blocks and techniques in the field of regional anesthesia. His special field of interest is in scoliosis and spine surgery and innovative techniques in regional anesthesia. I welcome Shekhar sir to start sharing his experience in how he does his high-risk hip surgeries. Welcome, sir.
Thank you, Dr. Prasad, for the introduction. My sincere thanks to Dr. Edward, Sivapada, and our whole team. And good morning to Dr. Rajesh. I have not met him personally.
Good morning, sir.
Good morning. I'll go on the slides. This is where I practice the Ganga Hospital now. It's 450 bed at
Shekhar sir, your screen is not shared.
Hello?
Your screen is not shared, sir.
Again, huh?
Yeah, you have to share it, sir.
I'll do again. Shared?
Yes, sir. Now it is getting displayed. Yeah, go to presentation mode, sir. Perfect, sir.
Clear now?
Yes, very clear.
We have THR, we have two options. One is cemented and uncemented, usually. Of course, the two doesn't make much difference for us, but except for the cement-induced pulmonary dysfunction or anaphylaxis in our setup. So choice of anesthetic technique is usually a big question mark, because who is to decide? Is it the surgeon or anesthetist or the patient? So most of the time, surgeons sometimes demand a general anesthesia, or sometimes they leave it to anesthetist the choice. Sometimes the patient demands either a spinal or a regional technique when you want a GA, and they ask for a GA when you want a regional. So it becomes a personal experience and your setup and what you want to do. So institution also makes a slight difference in the modification of the plan of the anesthesia. Generally, we always go for a regional anesthesia technique in our setup, unless there is a specific indication for a general anesthesia. I'll put a few of the things in the later slides. So usually the position is a problem for the things like it's a lateral most of the time, and supine with the support from the iliac crust area most of the time, it will be lateral position. So because of this, the regression of the spinal is faster, but the bleeding is less, and it's easy to raise the leg and make their positions more comfortable for the surgeon's sake, not for our side. One thing is, in this position, when you give a spinal in this position, then the drug goes to the dependent area, which is a non-operating site. So we'll have to be cautious about this. So what we usually do is give spinal in a sitting position, allow the spinal to take in a dense in the dependent of our operating site area, and then turn the patient once the hemodynamic stability is slightly better off. So what I want are in high-risk patients who are having a cardiac problem or a renal problem or any comorbid illnesses which is severe. They who require sick or ill are not only that, needing support most of the time. I want a foolproof technique and more familiar, which is more reliable and feasible and monitorable. So I get an answer like spinal. I want a 100% foolproof technique where the anesthetic plane is perfect for the surgeon and comfortable for anesthetist also, because in halfway through the patient start complaining of pain or anything like that, that will be going to be a big problem. So I take the choices spinal even in a sick patients. So between this spinal epidural and combined spinal epidural, it's all like a choice and it depends upon the surgeon's duration of surgery. Suppose if they are not fast, they're going to drag for little more time or technically complicated THRs, revision THRs, we always combine with the epidural. Certain aspects combining as advantages because you are reducing the dose of spinal volume, what you are giving. But this is not true always. So the level of block depends upon the volume of the drug and then the spread of the drug. The onset of action and latency also sometimes decided by the volume of the drug. Other thing, advantages of the spinal is we can repeat the procedure if the spinal is incomplete in the initial stage itself. Suppose halfway through it is, then accept the failure and the chance of failure is there in spinal. I do agree that always accept that there is my spinal can wear off before the surgeon finishes the surgery. So most of the time it finishes within the spinal time in our setup. Very, very, very rare to get dragging beyond the time of spinal, where we always have a epidural, and then epidural is not a foolproof technique where you don't have a control over your catheter or the spread of the drug. That's the most important point with the epidural. Putting epidural again is sometimes they combine a epidural with GA. So when you put epidural with GA, you'll have to be cautious after whether you're putting epidural catheter after the anesthesia or before anesthesia, because the negative to positive changeover is there. We do epidural along with elastomeric pumps or syringe infusion, but confirmation of proper placement and effectiveness of the catheter is more important than these procedures. Because you give a catheter and then suddenly when the patient is having little pain, you supplement or inject drug into the epidural catheter, the relief is not always guaranteed because we don't know where the tip is and the spread of the drug because of the elderly people, disc degenerative diseases, adherence of the dura, and so many things which can restrict our what you call it as prediction of the perfect displacement of the drug in the epidural space. So even now, there is a big trouble to answer this question. What should be the volume of the drug in the spinal? So when an assistant or a fellow comes and asks me, sir, how much to give for a spinal? It's $1 million question. So usually very difficult to answer the question, but still I take only two things into considerations. One is the height of the patient, and then the duration, what the surgeon is going to take. So I usually give at least a minimum of 2.4 ml, which looks a little high volume for everybody. A lot of people give 0.8 ml to 1 ml, but usually I give at least 2.2. The minimum drug for me is 2.2, where the level of block ascends beyond D10 or above the D10 to D8. If I give the volume little bit more, 2.6 in elderly patients, I make them sit for a while before I make them lie down, allowing the drug to descend down and then allow it to send up. Little gamble happens at this point because when you allow the drug to descend down and then make them lie down, the level ascending is not under your control or your prediction. Then the level of block is going to be a predictable or unpredictable. You will have to accept that. So that is where the epidural is helpful, because if you think that level is not ascending much, you can supplement initial itself in the epidural and confirm that you are comfortable with the epidural spread of the drug. If both of them synergistically go well, then your success rate becomes very, very good. So this level and then epidural spread, yours only your guesswork or how to go ahead is going to be partly your luck also. So there are a lot of what you call as spinal levels. You check with spread gauze or ask them whether you are feeling heavy in the legs or something like that. Is a big defeatable things. Usually I don't do any of these things, checking with the temperature or asking them to lift the leg and all, because the patient's acceptance or their anticipatory problems becomes worse when you ask them to do, and then if they are not able to do or they are able to do, and then it becomes a questionable value of your performance in the spinals. So what I do is, after the spinal, you just flex the limb, opposite limb or unaffected limb, and when the hip external rotates and the leg falls off, that means the hip joint is blocked. That says that the level is somewhere around D12, so that we can be safely go there. The second thing is the level of block is, again, we don't really know whether it is above D8 to D11. Why this is important is this are the most important things. When the level is above D8 to D11, the adrenergic supply from to the medulla, sympathetic supply to the adrenal medulla is blocked. So the hormonal compensation for fall in BP with the adrenaline rush is missing. So the hypotension is pronounced when the level is above D8. So loss of neural and humeral, the fall in BP will come suddenly from 160 to 80. So this is one of the reasons why people are afraid of spinals in most of the sick patients also, because the sudden profound hypotension is a thing against the spinal anesthesia. So they say that better to avoid spinal in these patients, sick patients. But if you understand this, why that fall is there, then you can compensate with the other methodologies. Now, if you see the dermatomes and the myotomes and the osteotome, the combination of things for the hip mainly, you can see that it should be above L4 is the commonest thing occurring in all these areas. So anything above should be to the level above L3, L2. For positioning, then you require D10, D11. So anywhere hip should be the level above D or above D10, minimum, I'm telling. D10 should be the minimum. So if you want the patient to be comfortable, then level better to be at D8 or D7. So if you are going to that level, be careful about the fall in BP. So anticipate this when you give a spinal. So volume now is going to be at least 2.4 ml or 2.2 or 2.6, depending upon that. If the patient is really tall, above 5.5, then I always give 2.6 as a minimum ml in the spinal. The reason, so if you take after the spinal, then we'll go why spinal is afraid of and how to compensate for that. So if you take the laws and reflexes which act on the spinal values. So after the spinal anesthesia, Mary's law doesn't obey. It doesn't obey the Mary's law. Mary's law states that heart rate is inversely proportional to the blood pressure. So when the blood pressure falls, we expect a tachycardic response as a compensatory mechanism, which doesn't happen under spinal. So once you give a spinal, the heart rate becomes lower and lower, and the BP also falls lower and lower. So the one another mechanism is Bizzol-Zaris reflux, which is a reflux from the vagal afferents from the myocardium on the ventricles to the brain, where when there is venous return is reduced, instead of producing tachycardia and hypertension, it goes to the opposite direction. It's hypopnea, decrease in respiratory rate, hypotension, and bradycardia. It is mainly because of the inadequate filling of the ventricles. The sympathetic input from the ventricles decrease. Also, sympathetic afferents are blocked. Another mechanism is the ventricle, when it doesn't distend with the venous return, the SA nodal activity within the intracardiac sympathetic fibers doesn't activate the SA node. So this causes withdrawal of the SA nodal. So it goes for the severe bradycardia and sometimes even to asystolic. Of course, this is extremely rare phenomena, where the reason is explained as this. So if now you know Mary's law is not going to occur, heart rate and BP is not going to compensate with the spinal, Bizzol-Zaris reflex is going to cause hypopnea and hypotension, bradycardia. So prepare with atropine already ready, filling up the ventricles, Now, your action will be. So I explained simply the fall in blood pressure, whether it is central, GA or regional, baroreceptors are supposed to act. So the neurohormonal response, the vasomotor center, and the vasomotor tone, adrenergic, and the vasoconstriction raise the blood pressure. So in a GA, if you take the neurohumoral response to be blocked, your death has to be phenomenally high. Of course, the modern drugs like propofol acts everywhere in the global positioning of the brain. The fall in BP is pronounced. Most of the people would have realized that when you give propofol, the BP from 160 can become 60, especially when they are inducing in elderly people. So GA doesn't give this fall in BP compared to spinal, what do you call it, as a protection. So general also causes this fall in BP. That's what I want to impress upon. So spinal is avoided in view of fall in BP is not a real statement in practical at least. So if you take the epidural spinal also, the sympathetic blockade, if it is below, the blockade is below T10, 12, your compensating mechanisms begin to act, neurohumoral response, bring up the BP automatically or at least to a safe level. Added to that, your sympathetic amines bring it a little bit more. So fluid if it is okay. Now the question comes in the elderly people where we don't have all these compensated mechanisms. Now you take the fall in BP in two aspects. One is the resistance vessels and the other in the capacitance vessels. So if you take both of them, there is a limit for them to dilate. For example, resistance vessels dilate when there is no vasomotor tone is being propagated from the medulla to the sympathetic system to the arteriolar area. So these vessels dilate to a certain extent because the muscular coat is quite thick. On the other side, you have capacitance vessels, which are veins, the lower limbs, which are going to dilate. Again, you have a capacitance vessels cannot dilate to any extent. It can dilate to the relative diameter of that venous tone. So because of this limit to dilate, both of them dilate, there is venous return diminished and diminish in the cardiac output, fall in BP. What is the effect of the sympathetic mimetic amines on these two vessels of the resistance and the capacitance vessels? If you compare, the resistance vessels constrict maximum when you give them sympathetic mimetic amines. That is what the problem begins, because if you constrict the vessels to a maximum, then the flow across the vessels are going to become less. Now, this flow, if it is less, it is not going to push the capacitance vessels stasis to back to the heart. So this is going to aggravate a fall in BP again. So because normally flowing is reduced by constricting the vessels to the maximum, sympathetic mimetic amines. So be careful about giving these drugs which will constrict the vessels beyond a particular dose. A resistance vessels should not be constricted beyond a particular level, or do the alternative. So we'll go for the alternative and check it up. So what is that we require now? Vasoconstriction. So fluids is initially you can rush, but according to the patients, again, we can give a preload to a level and then find out whether optimum load is there or not. I do the best thing is to immediately elevate the lower limbs, even the fracture limbs, a little bit carefully. So if you elevate the lower limbs, the resistance vessels remain the same, whereas the capacitance vessels empty. So the venous return is aided first. Is there a disturbance? Hello? Can you hear me?
No,
Yes,
sir, you
yes.
can continue.
Yes, it's flawless.
Yeah, okay. Suddenly I had a disturbance. They elevate the lower limbs, the gravity aided venous return goes to the maximum to the return back to the heart. The BP picks up immediately. Now, if you use a minimum of the vasomimetic amines, then the upper half of the body constrict to the maximum, the lower half to a level, which will raise the BP now. So this will be the first my mechanism to counter the fall in BP rather than giving too much of a vasoconstrictors. So noradrenaline and phenylephrine are sometimes we keep that refractory hypotension where there's, so you just either an infusion, few people start noradrenaline or phenylephrine. Now the latest, a lot of literature says the phenylephrine continuous infusion gives you a safety. I have a little reservations. These are all, please note that these are all personals. So you can do more than one way of things in the anesthesia. I think whichever is comfortable for you. I'm just expressing my view about that and why I do this way. So not that it is wrong or anything like that. So when you give a phenylephrine infusion, the vascular tone is increased. Remember, you are increasing the afterload, the contractility. So the microcirculation is cut off. So what happens is there is a slow, sustained hypoxemia in the peripheral tissues, leads to lactic acidosis. So one particular time, this acidosis is so much high, there is a sudden profound opening of the microcirculation causes profound hypotension. This hypotension is refractory now because the vasoactive amines will not work on that. So this continuous infusion beyond particular point is going to be counterproductive. So give noradrenaline or phenylephrine or mephentermine, whatever it is, but just to buy time. I should know why the BP has fallen beyond that particular level of capacitance resistance vessels, why it's not flowing through them. So my worry is in these people is try to fill the capacitance vessels. That's actually the preload. So constrict the resistance vessels to the level. Now, the rest of the thing is by the propulsive force or the cardiac contractility. That's called as a viscera ergo. So now the better inotropes at this point, when the resistance vessel is filled, capacitance vessels is filled. Now, the only thing is somebody to push this circulation to continue is going to be the contractility of the heart. So I will prefer inotrope, which will make this contractility better. So that will be the dobutamine. So my choice at this point will be dobutamine. Especially the cardiac patients whose EF is low, I prepare them in the pre-op itself. Start a dobutamine drug, identify the optimal rate. That's very important. I don't want the heart rate to be 120, 130, which is going to be counterproductive. So give an optimal rate, identify a rate at which the inotropic and chronotropic balance takes place. So my target of the dose will be heart rate below 100 and the BP of about 130 or 140 systolic minimum. So this balancing takes about nearly 45 minutes to 1 hour because we increase and reduce, keep dilly-dallying on that syringe infusion pump until we reach a constant rate and then find out at this particular point, these patients require this much of dobutamine to maintain the heart rate and the perfusion pressure in the peripheries. That will be my, methodology to make these patients, especially in the way of his 25%, 30%, 35% people. So now, if you compare the same thing with the general anesthesia, I just explain why I think this way. That's all. All are vasodilators in a general anesthetics. So when the vasomotor center blockade happens, it's almost like MAC bar. Now, if you don't monitor the depth of anesthesia, where are you monitoring, or how much possible for everybody to monitor the depth of anesthesia in our peripheral setup? So most of the time, very, very rare to monitor the depth of anesthesia. BIS is not. Also, BIS also is agent-specific signature techniques. So there again, you require different machines for different. So how low is the blood pressure is the criteria, and how high is yours when you give a general anesthetic. Again, the depth once happened, it takes a long time for you to recover from that. Because it's a generalized whole body, everywhere it's a general vasodilation, and both the resistance and the capacitance vessels dilate in general anesthesia. So the dose or vasoactive amines requirement is going to be more in general anesthetics. And how much it's back to the pressure is again difficult. So your response should be vasoconstrictors, fluids. Dose-dependent response has got a ceiling effect. So now you are going to cut off the inhalation agent and wait for the inhalation agent washout or the level of the depth to come back to the light plane. Now it's going to be an abnormal shoot in this patient. So heart rate is going to suddenly become high. BP is also going to high. When the heart rate is high, the demand-supply imbalance is going to be affected. So is it a safety mechanism? If you take the same similarity between this under spinal and then the fall in BP is going to be the same, where you get back this venous return quickly in the spinal is difficult in the general, under general. So my choice at this point will be relative safety is much better in the hypotension and things in the spinal rather than under G. So it's again, it's going to be like what you had in your patients, how much you had in your clinical, okay, the first 10 cases of yours, which determines your mind and thought flow towards that. So am I worried about giving a spinal? Is it so comfortable and everywhere and all? No, I'm worried about spinal also, because these are all my worries. Volume selection. So what volume to give is again will be to be honest, it's a gambling only. I choose according to that time, then give it off. So level is not under my control. A severe fall in blood pressure, adrenergic blockade, and then the regression time. We are not sure about if the level is higher up and then regression is not coming. Hypotension period is prolonged. So preload overload dangers are there. So especially in these elderly patients. So this still there will be a lot of debate going on crystalloids or colloids, normal saline versus interlactate, whether to give a whole blood or give it as in packed cells alone. Why to give plasma when there is not much of a blood loss, whether hemoglobin at 8 or at 10. And so many technically difficult unanswerable questions are still there. But still, spinal is comparatively better off with this. Now, when you ask about the epidurals, is it so comfortable with the epidural? Again, it's worrying is yes, because there are so much difficulty, technical difficulty in this, especially these elderly people will have a degenerative scoliosis. If you see the spines in these people, listhesis, scoliosis, and then disc degenerative diseases, disc prolapse, adhesions. So identifying the midline itself will be so difficult in these patients. And then whenever there is the identification as a problem, you always do an accidental puncture. Added to that, whether spread is going to be there or not. Where is your catheter tip? Is it going up as you think, or it's down in the sacral region? And especially you aspirate, you won't have blood. Finish the case or halfway through the case when they want to supplement, you aspirate, there will be blood in the catheter. Because the migration of the catheter can happen at any time without you doing anything. Even though you're fixed, aspirated, checked, everything done, because of the mobility of the surgical team or after the shifting the patient to the bed, you always see that the catheter is migrated intravascular. Because of the veins are so much dilated there, it's easily possible to have this. So these are all my worries about spinal and epidural. So does spinal fail? Yes, spinal fails. Between 1 to 17% it can fail. So never think that spinal is the ultimate. Spinal can still fail. Accept that fact. But in our clinical practice, spinal failure is very, very rare, very, very rare. That much I can give a conference. And again, if you think that spinal is patchy, you give a spinal and as usual, Murphy's law, the opposite limb will be paralyzed and your affected side will be unparalyzed. So it's become so embarrassing that the patient says, I'm not able to feel the other leg, but this pain is still persisting. But one comfortable thing is you can always repeat a spinal. That's possible. So that way this is easier to do it off. So Do epidural fails? Yes. 20%, 27% of the lumbar epidurals fails because various reasons. As I told, it is like what do you call it as the catheter placement, catheter, or not only the placement, the spread of the drug. Both these play a major role in the epidural. So these two things, when you're not under your control or doesn't happen as you wish, you have a lumbar epidural failure also high. So if you go to the GA, do you have a failure? No? So 1 in 20 patients remain aware but paralyzed during major medical procedures. So especially, we will be giving a drug, general anesthetic drugs, cautiously to these patients, worried about this response. Already sick, already very much borderline failures. So you reduce your propofol, reduce your thiopental, reduce your muscle relaxants, reduce your inhalation agents. So now we are erring on the safety, could be like a failure in the GA also. So there are incidences in these elderly people, even though clinical assessment goes well, there can be a cannot intubate, cannot ventilate, which is very, very less, like 0.003%. So GAS also has a similar risk factors. So if you have a converted spinal into a general anesthesia, yes, it happens again very, very rare in this about nearly 25 years now. I have done only 2 patients like this. Because here the level goes above D2. So there will be profound bradycardia and hypotension. And then apnea takes place. They have said that this apnea is not because of the level of the block. It is because of the hypotension of the brainstem where patient stops breathing. So I try to do mask ventilation and assist. So if the pickup is not good, you're not able to find it comfortable to ventilate, I immediately intubate because that is the best thing to do at that juncture. So when we are in a frantic, don't know what's going on in the scenario of the patient, where to go. So most of the time, about 50 to 70 or 80% of these patients who go for apnea, when you do a mask ventilation, they spontaneously recover. Usually they'll recover. Very rare to give a tube. But there are instances where you'll have to convert it to general anesthesia. The second conversion will be like patchy in spite of the epidural injection, and we are not able to control the duration of the surgery where it exceeds beyond our control. And unfortunately, the epidural doesn't spread well. Yes, naturally, we'll have to convert it into GA. So this is why I explained this. Hypotension, the level of the block, brainstem ischemia, and why I ventilate. So the most important thing I want to emphasize here is the monitoring under spinal anesthesia. Usually, they said the drug spread gets fixed in the spinal anesthesia in 20 minutes. There is a general opinion that after 20 minutes, hypotension will not occur and relative monitoring is not required under spinal. So this is suppose if the surgery is going to bleed, yes. If they are going to put a cementing, yes. I am talking in general about spinal anesthesia now. Please take it away from the total hip joint replacements. Spinal, when you give, you can see that there is hypoventilation. In the monitor, in the respiratory wave pattern, you see that it is not proper. That is the most dangerous things which can happen. In the lateral position, the regression has not happened, and your abdominal movement or weakness, then the dependent lung zones will become 3 to 4. So hypoventilation is leading to increased shunt fraction, but the problem is you supplement oxygen to all these patients. So saturation improves to 100, whereas CO2 retention takes 10. So there is a slow respiratory acidosis. Now, this is not going to happen in 1 or 2 minutes. This is going to take at least 30 to 40 minutes. So by 40 to 50 minutes after the spinal, there is a respiratory acidosis. Profound acidosis causes sudden vasodilation, which leads to even a cardiac arrest. There are a lot of people who would have seen the monitor like this, which showed the previous minute everything normal, heart rate normal, saturation normal, blood pressure normal. But suddenly the patient went in for hypotension and arrest. So that is explained by this phenomenon. So these patients should be monitored for the respiration rather than this heart rate and the blood pressure, because hyperventilation is not identified by any of these measures unless your ECG is in a proper placement, leads, plethysmography is followed up. So the moment I go into the theater when somebody else has given spinal anesthesia for monitoring or supervising, I always see the abdominal movement. If there is a doubtful, I always wake the patient up. And these are the patients whom the surgeons want the patient to be sedated. So invariably, we give narcotics to these patients. So the danger is level of block, hyperventilation, narcotic supplementation, which reduces the sensitivity for CO2 retention. So all this put together, there will be severe respiratory acidosis and can go leading to an arrest level. I usually reserve invasive arterial pressure monitoring because I don't know, I'm exceeding the time. Resistance vessels, vasopressors, perfusion pressure, tissue hypoxemia, lactic acidosis, and fall in surges in pressure is usually very, very less under spinal anesthesia. If you take the first 3 to 5 minutes, the resistance vessels get filled up, vasopressors make the constricts of the capacitance vessels, and the resistance vessels get filled up. Perfusion pressure is maintained by the facet ergo or the propulsive force by the heart. There is usually the beat to beat variation doesn't happen as in general anesthesia, where general anesthetics are myocardial depressants. So this doesn't happen here. The only thing is lactic acidosis in the peripheries. So beat to beat variation is not there. I usually don't do the invasive arterial pressure monitoring unless it is indicated. So do I reserve my spinals? Yes, I do give GS. If you have patients like this spine operated, and there are patients who have bed sores in the back, patients unwilling for spinal anesthesia due to back pains, and severe degenerative scoliosis where the spread of the drug is going to be very, very difficult, and then coagulopathies. So of course, coagulopathies better not to operate, but there sometimes we do aspirin, clopidogrel started patients, emergency or something like that, we'll have to go for a GA. The one other thing where I 100% give GA is the ankylosing spondylitis, where spinal and epidural is almost nearly impossible. So these patients, I prefer a fiber optic or video laryngoscope intubation well before doing positioning or anything. Between these two, which you think is better, bradycardia and hypotension or tachycardia and hypertension? So there are a lot of things talked about rate pressure product a little bit earlier. Now this rate pressure product is not much talked about. So spinal causes bradycardia and hypotension, whereas GA causes tachycardia and hypotension. So the rate pressure product is maintained, but the demand supply ratio is going to be affected. So heart rate at the lower level is relatively safe than the heart rate at a higher level. Again, it is like more of a theoretical. One another thing is this compare between the stress response blockade of the MAC bar and the depth assessment designations, because there is a lot of talk about stress response is blocked under regional anesthesia, and general anesthesia doesn't give a safety margin on that. So when you take this stress response blockade, the spinal anesthesia has to be above D8 or at least D6 level, so that the adrenergic medulla doesn't respond to any of the stresses. Same thing, if you take the general anesthesia, the MAC bar has to be there to up to the depth of the level of the medulla oblongata, which usually we don't maintain. We maintain somewhere around the brainstem area levels only. So if you compare the stress response, it's both ways, it is the same. Spinal anesthesia also has a stress response. General anesthesia also has a stress response. And stress response is important for the wound recovery or wound healing. The same way in the general anesthetics, why I worry is there are 3 limbs in the general anesthesia of modern anesthesia: narcotics, inhalation agent. So if you give a narcotics, it's very difficult to take it back or reduce it, where we don't know the sensitivity of that individual. 1 mic per kg of fentanyl at this age group may be sensitive, or few may not be sensitive to that 1 mic fentanyl. So difficult to judge the dose at that. And then reversal from that depth, from the medulla oblongata to the brainstem, to the thalamic level, to the cortical level back, is going to be a long time. And then the cognitive function between the general anesthesia and the spinal anesthesia, relatively spinal is relatively better, because moment the surgery is over, they are close to their relatives, the known faces. So the cognitive function is relatively better. So how about post-operative? Cognitive incidence is about 9.9%. Very difficult to prevent because it's individual sensitivity. Only thing is we'll have to rule out the organic lesion and electrolytes, renal function, or most of them it is supportive. And IC cycles also big. So 2 things in the post-op period of these total hip replacements persons. One is the cement-induced pulmonary dysfunction. Second is the basilar deletasis due to the position. So one is oxygen supplementation to any of these patients, bronchodilators. The only thing is I don't give this incentive parameters to these patients because it's going to affect further, because they are taking a deep inspiration against airway resistance of the balls. Instead, ask them to blow the balloons with the pressure so that the re-recruitment or recruitment of the alveoli takes place within the positive pressure in the lungs. And early mobility will be the another like ERAS programs. So we have blocks. One is on arrival. Moment the patient comes with a fractured neck or something like that, immediately we give a block so that at least patient's pain is relieved. Also, this block is repeated pre-procedural in the pre-op room so that these patients will sit comfortably for the spinal and epidural so that we can give that. So usually we do the 2 blocks, most common is suprainguinal fascial and the lumbar plexus, because there are 17 muscles around the hip. To completely block these things is very, very, very difficult. I won't say that suprainguinal, my fascial block gives complete pain relief. No. But when we makes them sit for the spinal, at least 60 to 70% of the pain has come down. Patient gives better compliance to that. The reason is again that Hilton's law, because whichever muscle crosses the joint gives a twist to the joint so that the thing is loose. And finally, for my spinal and epidural, I always think about this Murphy's law. Anything that can go wrong will go wrong, and nothing is as icy as it looks. It's not that icy as I talked about spinal. Everything takes longer than you think it will, because spinal time is not predictable. In few, it be 2 hours, few, it is 4 hours. So both ways it's possible. So be prepared mentally, accept things, your failures. That's all. Thank you very much for your patience hearing.
Thank you very much, sir. It's a wonderful sharing. It also cautioned us in many aspects because many times in peripheral steps, they just tell escape off with the spinal. But only if they know what a spinal can cause, we should take more caution. We'll take the questions in the end, sir.
Yes, sure. Thank you.
Next, I introduce the next speaker, Rajesh sir. Rajesh sir, welcome, sir, for this forum. He is the ex-assistant professor in BJMC Ahmedabad, and he is the head of critical care and trauma in Mahavir Specialty Hospital previously, and he is the ex-HOD of Marina Grand Hospital, and at present he is the medical director of UNM Children's Hospital in Surat. He has 26 years of experience in anesthesia, and his areas of interest are in ultrasound-guided regional anesthesia, difficult airway, point-of-care ultrasound, and especially segmental spinal anesthesia, both in adult and pediatrics. Welcome, sir, to share your experiences in patients with difficult surgeries. Welcome, sir.
Rajesh, sir, please unmute yourself.
Yeah, good morning to all, and thank you very much to Dr. Rajesh and team for providing me this opportunity. So today I am going to talk about high risk hip fractures or the hip surgeries, how I do it. So can I have my slides? Slide sharing is there?
Can share your screen, sir.
Yes, just a minute. So I'm Dr. Rajesh Shah, Medical Director and Head of the Department of Anesthesia at UNM Children's Hospital. So this is the hospital where I work right now. I have 26 years of experience for the anesthesia. And when it comes to the hip surgeries, more than 1,500 probably high-risk hip fractures have been done with the different techniques like GA with regional anesthesia, sole regional anesthesia, and regional anesthesia, combining of the blocks and spinal anesthesia for the hypobaric or isobaric drugs utilization. So, as the previously sir had told about the spinal anesthesia and regional anesthesia, the most important thing everybody has to understand that it is not any single technique is safest. No technique is safest. The person who is carrying it is the most important. So they has to understand the technique, its implementation on the physiology and its complications, and should understand the goals of the anesthesia, whatever technique one might be using. So today I'm probably talking more about the regional anesthesia combining with the any kind of the GA. Like GA, when I say it's kind of the IV sedation, or most of the times is the inhalation sedation. So that is that preferred technique for me for GA with RA, or RA followed by the GA like inhalation sedation. So when we talk about the RA, that is regional anesthesia, as sir also had mentioned that we have to understand the dermatomes, myotomes, and osteotomes about the area where we are getting operated. So that is one of the most important thing as an anesthetist we have to understand. So coming to the hip surgeries, most of the times it's an IT fractures or neck of femur fractures, or it's planned hip replacements or hemi replacement arthroplasty. So when we are talking about the hip surgeries, and different kinds of surgeries are performed for the IT fractures, like IT fractures, DHS, dynamic hip screw fixation, or PFN, percutaneous femoral nail, either short or neck is to be inserted. Sometimes for the hip fractures, when it is a neck, or some dicey discrimination, some people may go for a THR or HRA. So coming to the types of the different surgeries in the hip, if we talk about the dynamic hip screw fixation, and if you imagine the surgery where what are the dermatomes will be involved and what the osteotome and myotome, then we will talk about the dermatome that will be coming from the lateral femoral cutaneous of the thigh, because our incision is going to be on the lateral part of the thigh. And same way for the myotome, it will be coming from the femoral nerve. And again, the bone involved for the surgery is that is a femur bone, and it's supplied by the femoral nerve. So for the DHS, there are multiple things, multiple options are there. Lumbar plexus alone can work for the analgesia or sole anesthesia. If we add FICB with the sedation, that also can work. And femoral nerve block with the LFCN is also will be taking care of the analgesia or the surgical anesthesia for this surgery when we combine it with either sedation or with the inhalation sedation. That we'll be talking later part of the session. Again, for the percutaneous femoral nerve, lumbar plexus, as we have to understand when we are performing lumbar plexus and sacral plexus both together, it will be providing the effect like the unilateral spinal anesthesia. So you can perform any kind of a surgery on that limb where lumbar plexus and sacral plexus have been given. So lumbar plexus might be common for the hip surgeries wherever I am describing. So again, coming to the PFN, the some if we talk about the dermatom, where the incision is going to be for the PFN, that might include the terminal branches from the sacral plexus or the sciatic nerves, and even few of the myotomes will be involved for the incision. But otherwise, major portion of the myotomes and osteotomes will be coming from the femoral nerve itself. So either we can go for the lumbar plexus and sacral plexus, or lumbar plexus with the LIA, or even FICB with the LIA plus GA or inhalation sedation or IV sedation. So that can be done for the PFN. When we are talking about PHR or HRA, most of the things will be remaining same, but the hip joint capsule is supplied, posterior portion will be supplied from the terminal branch of the sacral plexus, so that we have to take care of the again. So LPB and SPB would be the better one for the if we go for a alone block. But as we usually had performed it with the inhalation kind of the sedation or IV sedation, and of late I have started is doing with the combining multiple kind of the spinal anesthesia and blocks with the isobaric or hypobaric drugs. So this was the matter about the hip surgeries and blocks, which blocks can be effective for the which kind of the surgeries. So the another portion included in the hip surgeries is acidabulum fracture, where again LPB, SPB or GA with FICB and LFCN block will be suffice. When we are planning for the entry approach, the femoral and LFCN will be required with the osteotome involved for the LPB. So when I am talking about the LPB lumbar plexus block, I will briefly go through the lumbar plexus detail also, because if I don't elaborate on that, then it will be not enough justice to the people. So lumbar plexus, that includes ilio-inguinal, ilio-hypogastric, laterocutaneous of the thigh, obturator nerve, and femoral nerve. So this is a lumbar plexus running over the anterior surface of the psoas muscle. Indications, as we already have talked for the indication, hip fracture, THR, HRA, anterior thigh and knee surgeries. So talking about the different approaches for the lumbar plexus is a Viney's approach. Viney's approach is usually considered as a lateral approach. In this approach, we have three lines are there. The one line passing is one line is joining the spinous processes, and that is going in the midline. The one line passing from the PSI, posterior superior iliac spine, and the Tuffier's line, it is drawn between the highest point of the iliac crest bilaterally. The needle incision site for this approach is at the junction of a line passing through the PSIC and Tuffier's line. So this is a lateral approach where the failure rates for the lumbar plexus are high, because laterally you may skip off the lumbar plexus many times. This is on the patient. Again, we are going to discuss about Chine's approach. Chine's approach is more of like a medial approach. It's a peridural approach. So there are chances of the disaster are more here, because drugs, high volume drugs can spread to the peridural space, and which is not actually desirable. So that will cause a sudden hemodynamic decompensation. So again, this approach, Viney's and Chine's approach are not a preferred approach for the lumbar plexus. So this is a CT image for the Viney's approach, which itself shows it is very lateral. And coming to the Capdevielle's approach, which I always do with this approach. So talking about the Capdevielle's approach, again, the lines are same as one line joining the spinous processes in the midline, the one line passing from the posterior superior iliac spine, and the one line, which is the Tuffier's line, joining the highest points of the iliac crest bilaterally. The insertion of the needle in this approach will be on the line, which is the part of the Tuffier's line, which is in between the two parallel lines, is divided into the medial 2/3 and lateral 1/3. And junction of this point, we have to either go 0.5 centimeter cephalic or caudal for the insertion of the needle for lumbar plexus. In this approach, after inserting the needle, hit the transverse process and walk off it. And once you hit the transverse process, after that, within 18 to 20 mm or 22 mm, lumbar plexus roots will be hit, where we will be getting the twitches for the femoral nerve. But be aware of not going more than 22 mm beyond the transverse process, because it may cause damage to the vital organs like the kidney and bowels. So that we have to keep in the mind. The another one approach is the line should be drawn between the L4 and posterior superior iliac spine, and this line again has to be divided into the lateral 1/3 and medial 2/3. The needle should be inserted at the junction of these two. And this approach, most of the times you will get the twitches or for the both the lumbosacral plexus, and you may inject the drug at the single level for this approach, which will cover both the lumbar and sacral plexus. So this is a pictorial representation of the different kinds of the patient, where I have shown the distance from the skin to the transverse process may be variable as per the size of the patient, and it may vary from 3.5 centimeter to 8 centimeter or 10 centimeters sometimes. But once you hit the transverse process, the distance remains fixed for the lumbar plexus to hit as 18 to 20 or 22 mm. So be aware, again and again I am telling that be aware of, don't go beyond 18 to 20 mm or more than 22 mm beyond the transverse process. This is a pictorial representation of the lumbar plexus branches, femoral nerve, just L2, 3, 4, and the LFC and ilioinguinal and iliohypogastric. The one more thing here we have to remember is ilioinguinal and iliohypogastric, which may come many a times from the T12L1. So with the lumbar plexus, sometimes it becomes difficult to block it because when we are giving a limited volume. So in that case, you may require a local incision infiltration at the site of the incision. So I have made the practice that whenever I do the lumbar plexus and sacral plexus for the sole block, I always tell surgeon to infiltrate at the incision site in the lower concentration. This picture is very important, as we have to understand this very well. At here in the upper portion of the slide, where if you hit the transverse process at the edge of the transverse process, and then if you try to walk up the transverse process, there will be a very narrow angle, and the chances of the hitting the lumbar plexus behind the transverse process are very high. But as it is shown in below, if you hit the transverse process at the center of the transverse process, and then if you try to walk off on either side of the transverse process, then you will have a very acute angle crossing the transverse process, and there are high chances of missing the lumbar plexus roots. So this you have to keep in the mind. So whenever you feel that your needle is getting acute angle to get that walk of for the transverse process, you have to remove the needle and reinsert the needle either cephalic or caudal to hit the transverse process at the edge of it. So that will make your job more easy. Contraindications for the lumbar plexus: coagulopathy, sepsis, shocks, and sometimes antiplatelet drugs with deranged INRs. So this is a short video of lumbar plexus. If you can see the landmark, that is a posterior superior iliac spine, ischial tuberosity, Tuffier's line, the one line passing from the PSIC, and one line is joining the spinous process in the midline. And as I told you, medial 2/3 and lateral 1/3 junction is being visualized in this, and I am introducing needle 0.5 centimeter caudal to that point. You can see the video.
I am introducing needle at the mark point.
So I have hit the transverse process. I am trying to get top of it, and I have got the stimulation.
So you can see the contraction here.
Very good quadricep contraction.
This is the quadricep contraction what we are targeting. So now we will reduce the current here.
Actually, this case was done at some hospital where very advanced gadgets was not available. That we will be discussing later part of the session.
So this is at a 0.81. .65 we are getting it.
So we are decreasing the current, and we accept it from the 0.4. The two more
So
most
0.55
important things
it has been
when you
stopped.
are performing
So
the
we
lumbar
increase.
plexus to remember is never flush the needle or the side arm of the needle with any kind of a solution, and always keep open the side arm without attaching the
It is
needle.
coming
Because
at
by mistake, if you enter into the intrathecal
59
space,
also now,
you will be
and
the CSF
it is
will
not
auto
might be
flow,
not
and you will be
appreciable in
saved
video
from
that
some
much,
disaster.
but it is there at
Otherwise, you
0.9,
will
59.
inject a high
The
volume in
two
the
very
intrathecal
important
space.
thing is that we have to keep open the side arm.
And another most important thing is you have to check every time with the lumbar plexus lowering the current. up to the 0.2 mm, because if you are getting the contraction at the 0.2 mm, beware of it, because you might be in the intrathecal space again, even though CSF is not flowing. So don't inject at that point. You have to withdraw the needle, you have to reinsert and do the procedure for that. This is a sacral plexus for the same patient. The sacral plexus, posterior left and interstitial tuberosity line is drawn in between this, and proximal 1/3 and distal 2/3 of the junction is the insertion site for the needle, and you have seen the very good contraction for the sacral plexus. Now we are reducing the current here. So I will elaborate another blocks also, like femoral nerve block, which is also important. As if you are planning only DHS, then femoral nerve block is very much of helpful. So for that, PNS guided, because always USG is not available in the peripheral setup. So PNS guided femoral block is very much of help. So accurate landmark for that and identification for the landmark is very important for the PNS guided blocks to be successful. So this is how you have to palpate the femoral artery and draw a line over the femoral artery. Draw a line between pubic tubercle and anterior superior iliac spine. And after drawing a line over the femoral artery, you have to mark the point 1.5 centimeter lateral to this line and 2 centimeter distal to the line between the ASIS and pubic tubercle. So that will be insertion for your needle. This is again practical tip I would like to give you, because this is a sartorial twitch. When you get a sartorial twitch, don't inject here because your block will be failed here. Why your block will be failed? Sartorial muscle twitch is not a reliable sign because the branches to the sartorius muscle may be outside the femoral nerve sheath. So what do you have to do that? So then direct the needle laterally and advance some millimeter deeper to obtain the patellar twitches. So these are the few practical tips. This is again a FICB video. I have done this video with the epidural catheter, epidural needle, and
We'll go for a second pop.
you can see one pop already have crossed, and this is for the second pop I am doing. So we have crossed. Now I am confirming with the loss of resistance. It is very good loss of resistance.
Now we'll inject.
Now I will inject the drug here. We can introduce the catheter also from this epidural needle. If we have to optimize the patient for a few days, like 1 or 2 days, if you want to optimize, we can do this FICB with the epidural needle or the epidural catheter and provide the continuous infusion in those times, because then it will avoid the systematic opioid consumption and other painkillers, and it will make the patient more comfortable if the patient had come with the hip fracture. So now we'll discuss few of the cases which are done at very high risk. Those are very high risk cases. This was a 64-year-old male, had hypertension, diabetes, IHD, triple vessel disease, CVA, known case of epilepsy, and was posted for the DHS. His echo was showing ejection fraction was 15 to 18% only. And these are the medication which he was on, like a lot of anti-epileptic, anti-hypertensive, anti-diabetic, and antiplatelets medicines are going on with the lot of comorbidities. This case was done in 2014. So this was his echo findings. Pulmonary artery pressure was 76 millimeter of J, which severe pulmonary artery hypertension. This is the echo, the ILA, RV, LV, everything was dilated and had a grade 2 to 3 LV dysfunction. So this patient was taken into the OT, monitors was applied. One more disclosure I will like to do here. Whenever I am taking the high risk cardiac patient, I always do the arterial line and central line. In most of the patient, if either I couldn't get the arterial line due to some technical difficulties, or if sometimes some places where arterial modules are not available, then I might have been proceeded with without that. But otherwise, I always had a preference to take an arterial line and central line for all this kind of the high risk patients. So in OT, patient was taken and monitors were applied. Right subclavian central line was inserted under LA. Then injection propofol 40. Again, I want to do some disclosure as previously sir had maintained. Again, I will say the no technique, no single technique is safest or unsafe. It is the person who is using it is more important to understand its implementation, its complication, and its side effects, and how they counter the side effects provided by the technique. That is most important. So injection propofol 40 milligram IV was given, and I waited by clock for 120 seconds. So patient was nicely relaxed then, and IGL number 4 was inserted, capped on a spontaneous ventilation with the nitrous O2 and desflurane. So patient turned lateral then, and PNS guided lumbar plexus block was given to this patient. This was during the intra-op, the peak was taken. This is again one video which was taken. In this patient, it was in 2014, probably I had not taken the arterial line. Patient is breathing with the 0.7 max. So surgery is performed under the block only. Here the 0.375% of 18 ml of ropivacaine was given for the lumbar plexus. This is a very interesting case. It was presented during the COVID time. Patient had a hip fracture. This patient was a very high profile patient and very high risk patient. Here almost 10 to 14, 15 consultants were known to this patient and were available, means present outside the OT and inside the OT during the procedure. She was 82 years of the female. This patient was refused for the surgery at multiple centers, and then they came to me for getting the operated. This was an 82-year female, hypertension, diabetes, IHD. COBA was done 12 years back, had a severe DCM, severe AS with AR, severe MR, had some mild mitral stenosis also, severe PAH, grade 3 LVDD, left ventricular dysfunction. EF reported was 25% by clinical cardiologist, but when cardiologist himself did it, and he told me that, sir, EF is only less than 20%. So be careful. Cardiologist himself was very much scared. There was a resting wall motion abnormality. He was telling that if any complication occurs, we will not be able to resuscitate this patient, as there is a severe AS with mild MS and AR AMR. This patient was posted for the PFN, visited her for the PAC. As the patient got admitted, came to know that multiple doctors are known to him. When I did PSC, I have given the USG guided FICB and put the catheter over there. For the FICB, started the infusion. Abdomen was distended. That's what I found at times. So immediately RTI inserted, serum electrolyte I sent it, USG abdomen I advised. All came normal. Then patient shifted to ICU and postponed on that day. Holter monitoring done as heart rate was varying from 45 to 60. And then in Holter monitoring, we found to have intermittent short run of the VT. Next day, distension decreased after passing of 6 to 7 times of the stool. Rest status quo. Plan to insert temporary pacing, because as short run of the VT was there, we have decided to do it with the TPI, temporary pacemaker. So I introduced 7 fresh sheets IGV and TPI done. And then HB was 8.6. So PCV was also given before the day of the operation over 20 hours, and Lasix was also given as she was very fragile. Patient had a fall before 4 days. So by that time, native town physician had already stopped the antiplatelets, was put on an injection Clexane, which I don't feel comfortable, as this is not going to act as an antiplatelet. Surgery was planned the early morning. Patient was taken into the OT, and before shifting to the OT, when more PCV I started slowly. In OT, monitors were applied, right renal artery cannulation done under local. As already TPI was done, we had a availability of the central line access also. So when I inserted the arterial line, BP was 154/86. That might be because of some kind of this stress. I prepared the noradrenaline in 54 milligram, 50 ml and attached to the central line and put it on 0.1 ml per hour. This is my routine protocol. So if needed, we can immediately go on increasing the NORAD on the infusion pump, and that is running to the central line. Patient turned right lateral with all the monitors on going on. And as initial block was given with ropivac, can still see had some effect for that. And infusion was also going on. So it was in a very easy to put on lateral position for her. And then LPV was given with the 0.375% of levoanavin 20 ml and SPV was given with the levoanavin of 10 ml. So after that, patient turned supine, injection ketofol 2020 IV given, and I waited by clock. Usually in all this geriatric patient, I by clock wait after giving propofol for 120 seconds. It gives you a good time for the propofol to act. And then patients are most of the time are very good high relaxation, so we can introduce the IGL easily. So IGL number 3 is inserted again, capped on a spontaneous respiration with the nitrous oxygen and SEVO. Surgery went very uneventfully without any changes of the vitals. It was rock stable. Goals were what we decided: to avoid hypotension, to avoid extreme hypertension, to avoid fluid overload, maintain oxygen carrying capacity, and avoid any drug which can cause further decrease in heart rate or can cause severe tachycardia. So this was the reports. If you are able to see the echo report. ECG, pro BNP was high. These are the videos I had taken during the surgery. This time EPCO2 had some issues, so it was not with the TPI machine. This was at the last week. Patient was absolutely fine. Again, this one more case I would like to share with us. That was 73-year of male, had a right hip fracture and posted for HRA, which he was refused to operate by 3 hospitals. And it was actually not of mine case. It was one of the friend, Dr. Amit Jain, was a case. Actually, he refused again at that hospital and advised them to get referred at some of the big tertiary care center. But patient and patient relatives were sorry for फोन में जाने के लिए मैंने પછી બંધ કરી દે ફોન વાત કરી લે ફોન જે બંધ કરી દે sorry for the disturbance. No. Sorry for some technical glitch. Actually, some phone had come and I'm not being able to share it again.
Sir, your presentation is not open.
Stop screen sharing with you. No, खत्म भी नहीं किया.
So, Professor, sir, you can take up the questions.
Meanwhile, yes, sir. Meanwhile, let us take up questions which have come for Shekhar sir's presentation. The first question is on the choice of drug in spinal anesthesia. Sir, what do you prefer? Is it isobaric or hypobaric or normobaric drug? And which one do you prefer? Do you prefer bupivacaine or ropivacaine? What do you prefer, sir?
I usually give bupivacaine only and hyperbaric. Am I audible?
Yes, sir, you're audible, sir.
Yeah. The reason is two-way. If you take this isobaric and hypobaric and all, the baricity is only a transient phenomenon. You give it inside the spinal. Once the glucose dissolves inside, miscible, then the question of difference becomes less. Then what remains is the number of molecules of the bupivacaine, which gets diluted in the CSF and ascend up or go for the receptor side. So my assumption or my concept is this. So it doesn't make a gross difference between the hyperbaric, isobaric. It's only the number of molecules to the number of receptors. I don't know whether I conveyed the message to them. So I'm comfortable with this hyperbaric bupivacaine. Advantage is allow them to settle down so that the molecule alone get dissolved and then come up a little late so that the level doesn't go acutely high. If you take this, I don't know how to explain that. Suppose you have a blockade of up to D2 where you think that the number of molecules ascended up is high, but then the lower molecules which are not blocking the lower down may be a patchy one. Suppose you allow that to block more dense or all the molecules to all the receptors in the lower levels, the number of molecules to go up is going to be less. So the level of block going above a D6 or D4 is very, very remotely possible. So hyperbaric is advantageous over that. These are my concepts. I don't know whether it is debatable or it can be debatable. You can argue in any way you want.
Even I feel so, sir, because the levels are more controllable already. Once you give the spinal, we are out of control. At least hyperbaristic gives some amount of control. That is what I also feel, sir. And do you use any additives, sir? And what is your choice?
Yeah, actually, I am for not adding anything into the intrathecal. Even fentanyl also I don't use. So the logic is remaining the same. If you take, they have started using these additives from almost now 50 to 60 years now. If you look into the Miller who give the Cochrane database answers, he has suggested which are all the drugs that can be given along with into the CSF. Remember, he advises how much of ropivacaine or bupivacaine to be given into the intrathecal area for level and the surgeries, but he has said suggested drugs to add. There is no definite drug which to be added into the intrathecal. There is no suggestion at all. It is given like these are all the drugs which has been tried in this one. So Miller, even after such a long time of these studies, they are not sure about additives. Number one. Number two, if you add a narcotic into the things, CSF, it's going to percolate. It's going to cause varied responses into this, which is not going to be a definite analgesic effect of this nerve roots. Number three, if you have all these things possible, with the duration of action is not going to be in relation to the bupivacaine, then it is going to be a waste. So my perception or my thinking is that I don't want this at any given additive. So I never add any additives to this. If at all, into the epidural, in the pump, fentanyl. The only thing I add.
Sir, your experience with continuous spinal catheters, sir?
Really sorry, I have not done even one. The reason is again simple. By giving epidural continuous spinal, however less, if you give very less, it's going to stay in that area. If you're going to give more, it can percolate above. Okay, number one. Number two, how do you control this percolation once you give it to the intrathecally? Where is your tip of the catheter is going to be? Even if you then movement of the body is going to make surgical movements, or you are not going to make the patient move at all, then what is the need for the continuous catheters? So if you are going to take such a long time of surgery, patient is not going to lie down like that. So convert it into GA. Suppose if the surgery exceeds for nearly 2.5 to 3 to 4 hours, which patient is going to lie down? How much you can give sedation? So you have to convert it to general anesthesia. In that case, my relative safety will be more with the relaxants and reverse, and which patient will be completely awake and all, rather than metabolically inactive segments of the body for a prolonged period of this. So the muscles are paralyzed to that extent. It is spinal anesthesia, and then upper off is compensating for that for such a long time. Is it worth it? So if it exceeds, going to exceed a relative 3 to 4 hours time, I will always prefer GA.
Sir, in case you opted for a spinal, surgery is taking a longer time and your spinal wears off, patient complains of pain and becomes restless. How do you manage, sir?
No epidural catheter?
Without an epidural catheter.
Yeah. If it is in the lateral position, it's going to be a tough. You'll have to hold the mask, propofol, or cautious is hyperventilation again. And again, I am emphasizing on the hyperventilation. Once the patient has pain, relatively might ventilate better off. So if the airway is going to be trouble, any spinal patients always they get assessed for the airway and ready to intubate. This standard, what do you call this, basic necessities. If you think that you cannot intubate halfway through, then you'll have to prefer go GA and then put an epidural catheter for the support of analysis. The straight intubation only. There's no question of conversion to GA. That's what I said. Under anesthesia, spinal anesthesia, if the patient is apneic, that means the level of the brainstem ischemia is to that extent. If mask ventilation is not going to get him spontaneous within 1 or 2 minutes, immediately intubate and better to support with general anesthetics or low dose of inhalation agent, more of a mechanical ventilation. So mechanical ventilation, which is more necessary than a inhalation agent at that time, to the tube tolerant level of the inhalation agent.
Your choice for positioning the patient for a spinal anesthesia, sir. The analgesia you give for hip fracture patient, position the patient for spinal anesthesia.
Suprainguinal facial iliaca.
Do you use a catheter, sir?
Usually, I don't use catheters in these blocks because for the simple reason, after the ultrasound, you can repeat at any time. Previously, when there is a saline left over, if you want to repeat or inadequacy, the PNS is not eliciting the response. I don't know, conveying the message. You inject a drug gets fixed to the nerves, but the remaining solvent or a saline in that area is there for a longer time, which elicits the PNS with relative difficulty. Because once you inject the drug 2 ml in that, then the PNS response goes away. So repeating is going to be difficult with the PNS. So they thought catheter will be better option. Whereas ultrasound, you are going to precisely see the nerve. How many times you want to repeat. So better to repeat rather than give a continuous catheter, number one. Number two, lower limb, yes. It's relatively okay with the catheter because low dose is going to cause sensory blockade because the core fibers are motor, mantle fibers are sensory in lower limbs, which is reverse in the upper limbs. So if you want to give a catheter, it's better to be in the lower limbs than in the upper limbs. Upper limbs, I don't put catheters at all because it's going to cause only a motor paralysis rather than a sensory paralysis. Because of this facility, even in a supine position or lateral position, you give a QL block, you give a lumbar plexus block, you give a facial iliaca block, by ultrasound is going to be much easier than giving a continuous infusion over that and then causing a continuous motor paralysis. So I usually don't use catheters.
Very good suggestion, sir. I think Rajesh has ready only one question. Have you come across a disastrous bone cement implantation syndrome, sir? How did you manage it?
Me or asking him?
No, sir. In the perioperative period, that you have
to me only you are asking.
Yes, sir.
Yeah, okay.
You would have got many cases.
I had these problems. So there are two ways of looking this bone cement implantation syndrome. One is hypoxemia in the postoperative period. So these patients require continuous oxygen supply for next at least 2 to 3 days. There are two ways of this looking into this. This is not this what you call as a loss of HPV. That's the reason I explained behind this. So the shunt fraction is more. The ventilation perfusion mismatch in the zones, shunt fraction is more, they are become hypoxemic. So just supplement oxygen 2 to 3 liters by nasal prongs is more than sufficient and look for it. Second is anaphylaxis. We have lost 2 patients on the table. Moment cement is introduced. Nothing can be done. It's very, very difficult to retrieve them. We have lost 2 patients after the cement. Just put the cement into the femoral stem, one hit, hypotension, bradycardia, arrest. Nothing could be done to these people. We couldn't recover them. 2 patients were. At least one had a little bit sepsis and all. We thought it is the cause, but it's anaphylaxis of the cement, and we have no role to play in this situation.
So, thank you, sir. Rajesh, sir, can you share your screen?
Hello.
Hi, sir.
Hi. Can you able to see my screen?
Able to see your screen, but not the slide, sir.
Not the slide.
Yes, sir.
Now?
Now we are able to see. You proceed, sir.
Okay. But just a minute. Okay, I will proceed with that. Okay, sorry for some technical glitches what we have faced it. So I was going to share. Actually, I would like to say one thing about the previous case. That was the case. It was done in 2022, and then that patient again came with the opposite side of the hip fracture for getting operated to me again. And that now when she came again, we did it with the hypobaric spinal anesthesia combined with the lumboplexus. So that's just to have information. Then another one case I am going to share, that is a 73-year-old of the male had a right hip fracture, posted for HRA, which as such he was refused to operate by 3 hospital because as Dr. Amit Jain, who is routine anesthetist there, had told them to get operated at somewhere, and they went with the reports to multiple hospitals, but then he was refused. Then Amit Jain contacted me. We had a discussion for that. I had visited for the patient for the PSC. Patient had a hypertension, IHD, diabetes mellitus, severe stroke, had an acute infarct before 2 months and was recovered, had a hepatomegaly, likely to be a cirrhosis, and had some element of the CKD also. This was his paper which was written. He was on medicine like this, and patient was okay. So patient was on ramipril, carvedilol, clopidogrel, oral hypoglycemic agents, diuretic furosemide. Clopidogrel stopped since 5 days as it took long time to get ready for all the with all limitations. The ECG was showing LVVB, create was 1.5, platelet was 1.31, maybe due to cirrhosis. This was his ECG. Had a fracture hip. So echo, dilated LV, severe LV dysfunction, ejection fraction 20%, mild PAH, mild MR, global hypokinesia, preoperative chest X-ray, left lower region heaviness was that. Examination, tachypnea may be due to severe pain because he was panic because of pain, or FES because as SpO2 was 77 on room air. Mild wheezing was there. We started with the nebulization. This was his chest X-ray. In OT, patient was taken and monitored. After attachment of the monitors, I took a right subclavian center line, noradrenaline infusion as per my protocol I have started. Arterial invasive monitoring was not available in this setup. In this setup, there was no workstation also. It was in a Boyle's machine. Original plan was to give sole block, but patient was very much uncomfortable and constantly shouting something and had a severe pain, so decided to go with the GARA technique. So injection propofol 70 milligram was given and IGL-4 inserted again after waiting 120 seconds. Nitrous, oxygen, and ISO. It started with the 12 liter of flow oxygen nitrous because this was in a Boyle's machine. Patient was almost 85 to 90 kg. So nitrous and oxygen was 50-50, and this was with the Bain circuit. Now it started at 5 ml per hour. Patient turned to left lateral. Pain is guided. LPV threshold current was accepted as a 0.44 and 20 ml of 0.25% bupivacaine was given. And SPB, again, threshold current was 0.4 mA and 12 ml of 0.25% of bupivacaine was given. As I told initially in my lecture, when LPB and SPB I always say to the surgeon to give a local infiltration at the site of the incision. This was posted for the THR. It was a posterior approach. ATCO2 was available in this monitor but was not functioning, unfortunately. Vitals intra-op remained very much rock stable. Surgical time was 2 hours. As a part of MMA, Dexona was given, and the PCM with the tramadol was also given. Intra-op 40 mic Fenta, as we didn't have a AGM and vaporizer, so kept low dial on Goldman, and to compensate with the inhalation in this patient, I had used the low dose of the fentanyl opioid to get the proper tolerance of the IGL. Once the this was an uncemented bipolar, as I insisted for the uncemented, and then after completion of the surgery circuit, we disconnected it. Within 5 minutes, patient became awake and talking. Noradrenaline in 2.5 ml, and after 1 hour, it was stopped. Patient shifted to ICU with the O2 mask. Post-op NORAD tapered within an hour. Oral was started as soon as the patient shifted to the ICU. LMW was started in the evening. Antiplatelet was also started same day. Motor movement came at 8:30 p.m., almost 12.5 hours after block. Patient was pain free till midnight, was started around the clock, and patient is absolutely stable now after 24 hours. This patient was actually published in the newspaper, local newspaper also, and that gives some publicity to us. This was few of the videos. Intra in he is breathing on a paying ventilation spontaneously. Surgery is going on. This is again one more video. Sorry, this was the same video.
ट्रेन तो चलेगा.
This was at the time of the closure.
नहीं ले एवरी यूजिंग નથી ना
ना ना.
So thank you very much for providing this opportunity. And one thing I will like to say that since of late, I have started combining it with the, as I told earlier also, with the blocks and hypobaric or isobaric drugs in the spinal. And actually that had provided a good thing to me, because then GA also can be avoided for the most of the patients with that technique. Thank you. Thank you very much. Any questions are welcome.
Thank you very much, sir. Sir, for these high-risk patients, how you manage the post-op analgesia, sir?
Post-op care. Usually we put the, in my experience, whenever patients are combined, just a minute.
Regional blocks.
Yes, with the regional block, once patient comes out of a GA, like we remove the IGL in all the patient. It means even I had done, as I told, more than 1,500 of high risk this fractures with this thing, including of the very high profile patients, so many doctors, father and all that thing. But in each patient, my observation was once I remove the IGL, hemodynamics comes to the baseline. We don't need noradrenaline infusion support for more than half an hour to 1 hour. We just send them for 2 to 3 or 4 hours in ICU for observation, and then we make them shift to the room. So in post-operative care, usually all the routine oral medications are being started on the same day, and all LMWH usually we give to all these patients who are having this multiple comorbidity. And so for the post-op pulmonary embolism is one of the very much common with low cardiac output patients, and even in hip fracture it is a common thing. So that is one thing which we stress usually for the post-operative care. Otherwise, it routine some observation under ICU for a few hours or max 24 hours, and then we shift them to the room with all their medication and LMWH.
Do you have a protocol for this antiplatelet drugs, sir? Do you follow ASRA guidelines?
Yes, for lumbar plexus, usually I follow the this guidelines because it's as it is a deep block. But then, if patient is to be operated and patient is having some issues for stopping the antiplatelet, then for the hip fractures, I will, like I already described in my lecture, that the individual nerve block also will be of the help, like FICB, femoral, the LFCN for the things. Yes. Problems comes with the with antiplatelet if we go for the posterior approach. Then posterior approach will not be covered with our individual nerve block for like femoral obturator or this LFCN. So in that case, then I told this after giving the FICV, large volume FICV or the femoral nerve block, I usually ask the surgeon to infiltrate for the skin incisions. So that makes the life more comfortable.
Edward sir, do you have any additions, sir?
Sir, we can conclude, sir. So today's session was an excellent session. Segar Salya sir has highlighted the disadvantages of neuroaxial anesthesia, and Rajesh sir has highlighted the combination of GARA. So they have stick on to the recent guidelines. The recent guidelines and meta-analysis, what they suggest is combine GA and regional anesthesia is better for high-risk patients for hip surgeries. If you take neuroaxial anesthesia alone, it has a high disadvantage compared to GARA. So excellent presentation and excellent highlighting of the many recent guidelines. Thank you very much, Segar sir, Rajesh sir, and thank you, Surprasad sir, for coordinating this session. I thank the sponsor Akurla and the telecast by the A1 Logics Praveen, and also I thank the Anaesthesia TV. Thank you, one and all viewers. We will meet the next month with one more interesting topic. Thank you, one and all.
Thank you.
Thank you very much. Thank you, sir. Himself was very much scared. There was a resting wall motion abnormality. He was telling that if any complication occurs, we will not be able to resuscitate this patient as there is a severe AS with mild MS and AR-AMR. This patient was posted for the PFN, visited her for the PAC. As the patient got admitted, came to know that multiple doctors are known to him. When I did PSC, I had PCM with the tramadol was also given, intra of 40 mic Fenta, as we didn't have a AGM and vaporizer.